Good afternoon, everyone. This is Beth Green with Alliant Health Solutions, your Alabama Quinn QIO, and in partnership with the Alabama Nursing Home Association, the Alabama Department of Public Health, and Alabama Nursing Home and Long-Term Care Facility Strike Team. We are coming to you for the first time since what I believe was October 13th. And we're here today to talk about the ending to the public health emergency and CDC's most currently updated guidance. We know a lot of folks have been reaching out about that, and we certainly hope to provide some relieve some provider burden by providing you with information today. As in the past, we encourage you to put your questions into chat, and members of the stakeholder team will help keep an eye on that. We do have Katrina Magden with us, Leanne Hickston from Alabama Nursing Home Association. We have Dr. Natalie Baker and Wade McEnfee from Alabama Nursing Home and Long-Term Care Facility Strike Team. And then we have one of my colleagues from Alliant Health Solutions, Amy Ward. Some of you may know that name if you've reached out with NHSN questions to Amy and her team. And then, of course, we have Melanie Roderick here with us that will be presenting. We really appreciate your time in joining us today. And at this time, I am going to stop sharing my screen and turn it over to Melanie.
Thank you all for joining and taking the time to be with us today. I'm going to take a moment to just share my screen and then we'll jump right in. So as Beth mentioned, today we're just going to take some time to review the most recent updates to the CDC COVID-19 healthcare infection prevention and control guidance. So as you all know, May 11th was the official end to the COVID-19 public health emergency. And so CDC had to make some updates to their guidance that was linked to, for example, the COVID-19 community transmission levels, which is one of the biggest changes with the end of the public health emergency. That being said, CDC is no longer going to be publishing or capturing the data needed for the community transmission levels. And therefore, there had to be some updates related to the recommendations for admission screening in nursing homes, as well as broad use of source control. So we will dive in a little bit deeper into those details. But first, I wanted to just show you where you can find the updated guidance. So at the end of this call, you will get a copy of the slides that I'm sharing today. These are direct hyperlinks to the CDC guidance. So the updates for admission testing and source control can be found in the interim infection prevention and control recommendations for healthcare personnel during the COVID-19 pandemic. I will note and highlight, though, that there have been no changes to these other two guidance documents from CDC, those being the interim guidance for managing healthcare personnel with SARS-CoV-2 infection or exposure to SARS-CoV-2, or the strategies to mitigate healthcare personnel staffing shortages. So let's just jump right into the updated guidance. So with the admission testing, all healthcare facilities have been deciding whether or not they want to implement admission screening for some time, but as of May 11th, now nursing homes have the ability to choose whether or not they are going to be performing admission testing. So it's going to be at the discretion of the facility, and we'll talk a little bit about some metrics that you can look at to determine whether or not you will implement admission testing in your nursing home. So moving on to source control, the CDC guidance is really trying to get facilities back to where we were before the COVID-19 pandemic. So they're encouraging facilities to look beyond SARS-CoV-2 and really make decisions for broader masking that are based on the facility and patient level characteristics, while using some local metrics that could reflect increasing respiratory virus transmission in the community. And again, we'll be talking about some of those metrics that you can use. So source control is still going to be recommended for anybody who's suspected or confirmed with SARS-CoV-2 infection or any other respiratory infection. For example, those with runny nose, cough, and sneeze. You all know that COVID-19, the signs and symptoms are really all inclusive. It's really hard to tell whether somebody has a true signs or symptoms of COVID-19 or whether they have allergies. But the recommendation is if you have signs and symptoms of respiratory illness, go ahead, err on the side of precaution and mask. Additionally, anybody who has had a close contact or higher risk exposure with somebody who has SARS-CoV-2 infection should wear source control for 10 days after the exposure. There are a couple of instances where CDC is recommending that source control be used more broadly, and those are listed below. So the first one is going to be by anybody who is residing or working on a unit or area of the facility that is experiencing a COVID-19 outbreak or other respiratory infection. The second criteria is that source control should be used more broadly when should be used more broadly facility-wide or based on a facility risk assessment for those that are deemed to be at higher risk for COVID-19 infection when the community levels are showing an increase of respiratory illness in the facility or in the community, which kind of leads me to the third criteria. Facilities should implement broad use of source control when it's recommended by public health authorities. And an example of that is when the COVID-19 hospital admission levels are high. And we'll talk a little bit more about this metric on the next slide. Before we move on, if you are interested in reading or learning about implementing broad use of source control, you can find further guidance on CDC's core IPC practices webpage. Again, you'll be getting the copy of a presentation, and you can find the direct link to that webpage on the notes of this slide. So here are some potential metrics for broad use. The first one I just mentioned on the previous slide is the COVID-19 hospital admission levels. This is the metric that we are going to be recommending that facilities use to determine whether they need to scale up or down prevention control measures for their facility. And just a little bit about this metric, this metric has replaced the CDC community levels metric and is going to be the metric that is going to guide prevention decisions at the individual and the community level. The next three potential metrics that a facility can use are from a national surveillance perspective. And so I'll just briefly touch on what each of these surveillance systems captures, and then also share a little bit about a new local metric that we will be developing. So RESP-NET, this first option right here, is an international surveillance system that conducts surveillance for hospitalizations associated with COVID-19, influenza, RSV among adults and children. The data is obtained from select counties in 13 states and covers more than 29 million people and includes an estimated 8 to 10% of the US population. Moving on to the third metric, the National Emergency Department Visit Surveillance System, that provides a combined view of emergency department visits for multiple respiratory conditions, and it's tracked by the National Syndromic Surveillance System. And these data are obtained from a subset of emergency departments across the US. Alliant is the last national surveillance system that you can use as a metric. It monitors healthcare provider visits for respiratory illness that include fever plus a cough and or sore throat, also referred to as ILI or influenza-like illness, but it does not include laboratory confirmed influenza and may capture patient visits due to other respiratory pathogens that cause similar symptoms. So Alliant does not measure the extent or the geographic spread of flu within the state. One other metric that people can use for source control could generally just be during the typical respiratory virus season. So that's from October to April, just to ease implementation of broad use, facilities could opt to broad use of source control during these months. And as I mentioned, the Alabama Department of Public Health is in the process of developing an Alabama respiratory diseases dashboard that will be public or posted to our website no later than October 1 of this year. And the dashboard is going to use Alabama ED visits and hospitalization data to determine when respiratory disease transmission is on the rise. So this is going to be another metric that facilities can use to supplement when they will scale up or scale down their prevention measures in addition to the COVID-19 hospital admission levels. This is simply just a screenshot of where you will go to access the COVID-19 hospital admission levels. It's formatted very similarly to the way that the community transmission level metric was formatted. So you can navigate to this page by a couple of different ways. My suggestion would be to just Google COVID-19 by county and click on that first link. It will take you directly to the web page. You'll scroll down a little bit and go to this subsection called Know Your COVID-19 Hospital Admission Level. As you can see, you'll select the state, you'll select your county, and then right below will provide the hospital admission level with some recommendations based on the individual or the community level. You can also access this webpage through the COVID-19 data tracker, but you have to navigate around a little bit through the CDC COVID-19 data tracker to get specifically to the COVID-19 by county webpage. So again, my suggestion is to just Google it. Some of the web links in the updated CDC IPC guidance will take you directly there, but then some of them also link you back to the CDC COVID-19 data tracker. So if we have some time at the end, I'll be happy to share my webpage and show you how to navigate to the COVID-19 by county via the CDC COVID-19 data tracker. And again, this is the metric that we are recommending that facilities use to determine when to mask on a broader level. So I've mentioned individual and community level prevention strategies that can be used based off of the COVID-19 hospital admission levels. So let's just start with the individual prevention strategies. So when the COVID-19 hospital admission level is medium, facilities can consider broad use masking for those that are high risk of getting very sick. So this is, again, a link that you can click on, and it takes you to CDC's webpage that has a list of conditions that would be considered high risk. It's very inclusive, and just some examples could be those with cancer, those with chronic kidney or liver or lung disease, diabetes, and the list goes on and on. The way that facilities, if they decide to adopt masking at a medium level for those that are high risk, the facility could provide education to staff and just say, we will be adopting broader use of masking for those that are high risk when the COVID-19 hospital admission level is medium, and this would be inclusive of all of the conditions that would put you at a higher risk of COVID-19 acquisition. And then those that have those conditions could go ahead and start masking at a medium level. On the other hand, if the COVID-19 hospital admission level is high, then we are recommending that all people in the healthcare facility-wide would implement broader use of masking. So those were the individual level prevention strategies, but the next thing we're going to touch on is the community level prevention strategies. When the COVID-19 hospital admission level is medium or high, facilities can consider implementing screening testing. This is specific to admission screening testing. Again, that is going to be up to the facility, whether or at the discretion of the facility, whether they will continue to conduct admission screening or if they're going to use a certain criteria to determine when they would put that back in place. So those were all of the updates that were linked to the COVID-19 community transmission levels that were updated. Now we're going to switch gears and talk a little bit about outbreak reporting. So this was also another change that came along with the expiration of the COVID-19 public health emergency. So we have decided to adopt the CSTE and QORA COVID-19 outbreak definition. It's a little bit different than what y'all have been used to reporting in the past. And so I'll just touch on what the new criteria is, but I will reiterate that the reporting form, the reporting location is still the same. Any potential COVID-19 outbreak would still be reported via the potential outbreak submission form. So the first criteria is 1 or more facility acquired COVID-19 cases in a resident, or 3 or more suspect, probable, or confirmed COVID-19 cases in healthcare workers with an epi-linkage and no more likely sources of exposure for at least one of the cases. So using this first criteria, when we talk about facility acquired, we are talking about a COVID-19 infection that originated within the nursing home. It would not include a resident that was admitted with COVID-19 and needed to be placed in transmission-based precautions to finish out their isolation, or it would not be inclusive of residents who were placed on quarantine upon admission and then tested positive during their quarantine. So I know that not with this most recent update, but the update before this one, it was no longer recommended for people who were asymptomatic to be in transmission-based precautions. So many of you may not be placing people into transmission-based precautions upon admission, as long as you were doing that testing. And this is, of course, before the most recent update. But there are some criteria that CDC's website lists of when you would consider quarantining somebody. So somebody who is not able to wear a mask or not able to be tested, if they're moderately or severely immunocompromised, if they are residing on a unit with somebody who's moderately or severely immunocompromised, or if they are residing on a unit that has evidence of COVID-19 transmission or COVID-19 outbreak. So again, those two types of residents would not be included or meet the definition for a facility acquired infection. So moving on to the second criteria, which has to do with healthcare personnel. We are looking for 3 or more with an epi-linkage, and at least one of the healthcare personnel doesn't have a more likely source of where they would have acquired it. So for example, you've got 3 healthcare workers, and 2 of those healthcare workers have someone within the home that has recently tested positive. When we are talking about epi-linkage, this definition is specifically for those that have had the potential to be within that 6 feet for longer than 15-minute criteria, and they've been, while they were working in the facility for the 7 days prior to onset of symptoms. So an example of this is that they were either working on the same unit or they worked during the same shift, and they have no other likely sources of infection outside of the facility. There's going to have to be some judgment when determining epi-linkages. And you really have to weigh whether or not transmission may have occurred within the facility, or if this is truly an infection that was acquired elsewhere. So we'll talk a little bit more about that on our last FAQ. But I do have a couple of examples of when you would report an outbreak. And these are just very general examples. And we'll, like I said, talk a little bit more about things, situations that would be less evident of epi-linkages and what you would do in those situations. So the first example is you have a positive employee and you begin your outbreak testing and you identify a positive resident who meets the facility acquired definition. The 1 positive resident would need to be reported as an outbreak. The second example is you have identified a positive employee, you begin your outbreak testing, and you identify 2 other employees who worked on the same unit. and at least one of those employees does not have a known exposure outside of the facility. So this would need to be reported as an outbreak. And again, we'll go over a couple of other examples before the end of the presentation. I did want to highlight some things that haven't changed. So I'll just go through this list and then we'll talk a little bit about each of these topics. So the outbreak testing criteria has not changed. Facilities should still initiate outbreak testing, whether that be close contact or broad-based, upon the identification of a single case in the facility. I just want to reiterate that there is the difference between outbreak testing and outbreak reporting, which we'll talk about on the next slide. Additionally, facilities should still have a way to identify and manage people with suspected or confirmed COVID-19. So this relates back to posting visual alerts for when people should not come to work, or when visitors should not be visiting the facility. Also have a way to manage those that are known to have COVID-19 infection. So we'll talk a little bit more about that for resident placement, but just having processes and protocols in place to make sure that everybody is educated on not reporting to work and not coming to the facility to visit based off of having a positive test result, being a close contact, or any of the other criteria that is listed on the CDC website for identifying individuals with suspected or confirmed infections. The isolation and quarantine, and again, if quarantine is warranted, timeframes have not changed. So it's still going to be 10 days for residents, 7 days for healthcare personnel. Same with quarantine, 7 days as well, as long as all all testing results come back negative. The frequency of testing asymptomatic close contacts has not changed. So facilities should still be testing individuals on day 1, 3, and 5. The COVID-19 PPE recommendations are still the same. So that's gown, glove, eye protection, and an N95 respirator. Resident placement remains the same. So ideally, you would have a single person room with a dedicated bathroom for those that are identified to have COVID-19 infection. We know that this is not always feasible, just considering the facility layout and the infrastructure and really how big the outbreak is. So there is guidance that says if a single person room is not available, then you could leave the person where they are. If you have, if you're doing testing and you identify lots of cases on the unit, then you could just dedicate that whole unit, similarly as we would in the past, as your COVID-19 unit. And if you can, have dedicated staff. Additionally, the visitation requirements from CMS, there was an updated memo, QSO 2930, that was revised May 8th, 2023, to go in line with the CDC IPC updates that were made as well on May 8th. So if you haven't seen that, you can go to the CMS site and search for QSO 2930, and you'll navigate to the most recent revised version for the visitation requirements. And lastly, the environmental infection control practices have not changed. So moving into some questions that we've gotten since the change in the guidance. First question is, what constitutes an outbreak? So the outbreak investigation process has not changed. As I mentioned, facilities would still initiate that outbreak testing, either close contact or broad-based upon the initiation of one case. And depending on what your test results show, that will determine on whether you will report the suspected outbreak to ADPH using the potential outbreak submission form and referring back to the outbreak definition that we've newly adopted from CSTE and CORA. Next question, how should facilities implement testing and masking when a case is identified? So most of you are probably familiar with this guidance, but just to reiterate, Close contacts or all individuals on the affected unit should be tested on days 1, 3, and 5. If additional cases are identified, facilities should shift to a broad-based approach, if not already being performed, and continue to test every 3 to 7 days, preferably every 3, if you're using antigen, until no new cases are identified for 14 days. Same question, just some additional guidance. If no new cases are identified on days 1, 3, and 5, close contact should mask for 10 days after their exposure. If you're using the broad-based approach, the conservative approach would be to have individuals masked for 14 days, but facilities will need to make decisions based on the severity of the outbreak. So just to provide a little bit more context on this response, if you're taking the contact tracing approach, that means that you know all of the close contacts and when they were exposed. Assuming no new cases are identified on those first 3 rounds of tests and no other individuals are presenting with symptoms, then you could stop wearing the close contacts could stop wearing source control 10 days after their exposure. If you're doing a more broad-based approach, then you're a little bit more conservative, and because you aren't certain who's been exposed and when that exposure may have occurred. So in that situation, assuming no new cases are identified with the first 3 rounds of testing and no other people present with symptoms, you would err on the side of precaution and have everyone on that unit or facility wide mask until day 14. But it's not unreasonable if a decision is made to stop masking at day 10. Again, there's no perfect approach. A lot of these decisions will have to be made at the ground level, taking into consideration the severity of the outbreak. When is a facility not an outbreak, considered not an outbreak? This has not changed. The criteria is still no new cases for 14 days. Do employees have the right to refuse testing during an outbreak? The response is that you should consult with your legal counsel. Facilities should have a process in place to manage these employees and have a plan for what they will do if testing is not possible or the employee is unwilling. There is some guidance on CDC's website that facilities may consider work restriction for employees who are unable or unwilling to be tested upon suspected exposure. Without testing being conducted, healthcare personnel may return to work 10 days after the suspected exposure if they do not develop symptoms. But again, this is something that you should consult with your legal counsel about and have a policy in place if the situation does arise. More information on work restriction can be found under CDC's interim guidance for managing healthcare personnel with COVID-19 infection or exposure. Next question, if hospital admission levels are high, do we implement masking and eye protection for all healthcare personnel as well as COVID PPE for aerosol generating procedures? Facilities should implement universal use of respirators and eye protection during all patient care encounters when hospital admission levels are high. However, it's not recommended to wear COVID-19 PPE for aerosol generating procedures unless the person is suspected or known to have COVID-19. Next question, if hospital admission levels are high, do visitors also need to mask? So yes, when the hospital admission levels are high, it's recommended that people in the community wear masks, and so the visitors should also wear masks when entering your facility. How often should a facility check COVID-19 hospital admission levels? It would be reasonable for facilities to continue to use the same frequency that we were when we had the community transmission levels. So facilities were checking it on a weekly basis on the same day. And you can also use similar benchmarks that were detailed in the CMS memo. So for example, if the level went from high to low, you would wait at least 2 weeks before scaling back your prevention measures, such as broad use source control. However, if the level went from low to high, facilities would implement prevention measures immediately. So if that was a process that worked for your facility, I would recommend continuing with those same practices, just using a different metric. Do facilities continue to complete a COVID-19 long-term care investigation form for reporting cases that are hospitalized or have died from COVID-19? Yes, that has not changed. Please still submit those via the COVID-19 long-term care investigation form. We prioritize those for investigations. I will say, though, that NHSN will be updating their surveillance reporting form to include the aggregate number of hospitalizations. If you all have not already gotten an email about the the change, NHSN will be having a training on June 1st, which is a Thursday at 1 p.m. They're going to have a follow-up webinar with the same information on Wednesday, June 7th at 12 p.m. You can access the links to register on the NHSN COVID-19 long-term care investigation. COVID-19 long-term care module webpage. And it's the same information on each of those, so you would only have to register for one. I believe this is the last FAQ. If we have 3 or more suspected, probable, or confirmed COVID-19 cases among healthcare personnel with no common exposure within the facility in the past 7 days, for example, they did not work on the same hall or unit or come within 6 feet for 15 minutes or greater, do we have to report that to ADPH? So again, this is going to be a judgment call at the facility level. I mentioned that epi linkage is going to have to be, you're going to have to use evidence of what you know surrounding these cases among healthcare personnel. So for example, sometimes it's really clear what the epi linkage is. You've got 3 who worked on the same unit or the same shift, but it's not always as clear, and it's hard to identify where the infection was acquired or if transmission occurred within the facility. So let's say you've got, and this is in a 7-day time frame, if you've got 3 healthcare workers that tested positive within 7 days, but they did not work on the same unit, they didn't work during the same shift, the epi linkage could be that they work in the facility. It could be that broad of an epi linkage if they don't have any other known sources of exposure outside of the facility. So if all 3 of your employees say, yeah, you know, I haven't been around anybody who's been sick, nobody in my household's tested positive, that might be enough evidence to say, okay, there may be transmission occurring in the facility. We're going to go ahead and report this as a suspected outbreak to ADPH. I'm trying to think of some other examples. Let's say you've got 3 that have no overlap, but 2 of them, one of them just came back from vacation, the other one, their spouse just tested positive, but you still have that one that has no known exposures outside of the facility. It's meeting that at least one healthcare worker with no other known exposures, that would need to be reported as an outbreak. Again, the definition is just something that we use to reference. It's not all inclusive of all situations that you're going to come across. So if you're unsure, if you have any questions, feel free to reach out to your regional IP or myself. We can talk about the situation and determine together whether or not it would need to be reported. So those are all of the FAQs that I got beforehand. I think I got some emails right before the call with some additional questions.
And Melanie, we do have some questions in chat as well.
All right, we can jump right into those at chat and then from the chat, and then if we have some extra time, I'll look back at those emails.
Okay, perfect. Thank you. And thank you for, as always, a very thorough and informative presentation, Melanie. So one of the questions is, are these mask usage guidelines, recommendations, or regulatory requirements? And I did have one of our panelists respond to the other panelists, if you saw that, Melanie, or would like me to read that out.
I have not seen it. If you just want to go ahead and share the response with the group.
Okay, and so one of our panelists actually from Alliant, Amy, shares that as we move out of the PHE, the regulatory guidelines do not dictate specific practices. However, you do have to have an effective infection prevention and control program, and you will be held to this regulation via survey, and surveyors will look to your policies and practices to ensure you're following CDC or other evidence-based practices in your facility. Do you want to add anything to that, Melanie?
No, thank you, Amy. I would agree with that response.
Okay. Another's about the slide deck, and yes, it will be shared after the presentation. Was the use of respirator and eye protection for all encounters for all residents in the facility when hospital rate is high?
Oh, was the question, are respirators and eye protection recommended when the levels are high?
Yes.
Yes. So if
the use of respirator and eye protection for all encounters for all residents in the facility when hospital rate is high.
Yes, so if you look at the IPC healthcare guidance under implementation of universal use of source control, you'll see that it's recommended that facilities use respirators and eye protection for all patient care encounters when levels are high.
Okay, thank you, Melanie. And then should visitors be asked to mask when the facility is an outbreak?
So if you've got somebody who's coming onto the unit to visit a resident that is residing on a hall with an outbreak, I would say that to err on the side of precaution, they should probably also mask. To think that they would be held at a different standard just because they're coming from the outside in. I think if they're coming to visit a resident that's on a unit with an outbreak, they should also be asked to mask. And I don't know if others on the call have anything to add or would agree with that.
This is Amy. I would agree. I would encourage masking from visitors during an outbreak. You know, if visiting a resident who is positive, highly encourage masking and visiting in the resident's room.
Thanks, Amy.
Thank you, Amy. Okay, another question here or clarification. So we do not have to wear full COVID PPE when performing aerosoling generating procedures when admission levels are high.
So you would only need to wear COVID PPE if the person that you're performing the AGP on is suspected or confirmed to have COVID. If they do not, and the hospital admission levels are high, then it would only be recommended to wear a respirator and eye protection.
Thank you, Melanie. Okay, there are currently no more questions or comments in chat. We have about 5 minutes left. Oh, wait a minute. I think there's Wade. Would you like to read that question out? I forget we've got the Q&A too.
Absolutely. So the question that was asked in the Q&A was, You said masking for medium or red levels. What about eye protection? Can you talk about eye protection more?
Sure. So when the hospital admission level is medium, it's recommended to use broad use of source control for those that are high risk. When the hospital admission level goes to high, that's where we are recommending that broad use of source control and eye protection be worn among staff for all patient care encounters. So you don't necessarily need to wear eye protection when the hospital admission level is medium. It would only be required, be recommended when the hospital admission level is high.
Thank you, Melanie and Wade. Wade, are there other questions in Q&A?
No, that was the only question in the Q&A. But I would check with Katrina to see if she had any questions emailed to her.
Okay, yeah, Katrina, if you don't mind sharing, and while you're looking at that, let me go ahead and share a couple of other chat questions. Source control definition is surgical mask or respirators. So if the hospital admission level is high, should we only wear respirators as source control, or are surgical masks okay?
So the way that the guidance is written, it references when the levels are high to use a respirator and eye protection. Facilities can use a well-fitted face mask for those that are considered high risk when the level is medium. But from my understanding, it's recommended to be a respirator and eye protection when the levels are high. Amy, I don't know if you have anything to add on that, or if the facility could opt to wear a well-fitting mask and eye protection when the levels are high. That was not how the guidance was worded, but I know that surgical mask is an option for source control.
So I would just say from a practical standpoint and from a regulatory standpoint is you need to have a plan and follow your plan. So the easiest thing to do would be to implement respirators and eye protection when levels are high across the board. If you have a lot of staff pushback on that and you choose to go to a lower level like surgical mask, then it would probably be wise to say, okay, during high hospital transmissions, we'll wear surgical masks or respirator if the employee chooses, and eye protection. But if the facility is experiencing an outbreak, then we will move to all respirators. So having a plan that's written and ensuring that you are following that plan is really where we need to get with our IP practice.
Thank you, Amy.
Did get one question in, if you'd like for me to go ahead with that.
Okay.
Sure. It's this is concerning OSHA guidance for testing. Is the OSHA requirements for testing, if not fully vaccinated, if in the workplace at least once a week or within 7 days of returning to work, if away from workplace for a week or longer, still in place despite other guidance from the CDC?
I am not familiar with the OSHA guidance. I don't know if anybody else on the call can speak to that.
This is Amy. I don't recall OSHA guidance dictating testing or return to work strategy. I think you're going to find that also within CDC guidance for return to work and when to exclude a healthcare worker from work for any illness, not just COVID-19. And again, having a plan in place and policies in place and making sure those are followed.
Melanie, no, thank you, Amy. Another question, can you confirm that staff not vaccinated right now must still do enhanced source control?
So the source control recommendations don't include whether or not individuals are vaccinated or not. So I know that there was a memo that went out that said that their facilities would need to implement these additional precautions for those that are not up to date with their COVID-19 vaccine. But I think the facility is going to have a plan in place to describe what masking policy or practices that they want to implement based off of the hospital admission levels. And then, have a separate section that talks about additional precautions for those that are not up to date with their vaccine. Amy, did you have anything to add on that, or anybody else on the call?
I agree. I don't have anything to add. Thank you.
Okay, and one last question here in chat that I see, and I know we're 2 minutes over, but great questions, and we appreciate your engagement. And I believe you referenced the QSO 2930 memo on this, but please clarify the screening guidance for employees and visitors. That may have been the visitation you referenced. So please clarify the screening guidance for employees and visitors.
Okay, so I'm assuming this is, we've gotten some questions. Do we still need to ask the COVID-19 questions as people are coming in? Do we still need to take temps? So that is not necessarily required for every single person that's coming into your facility, but the facility does need to have visual alerts or signage upon entryway or in the break rooms on when people should really not be coming into the facility. You don't have to have a checklist or physically be taking everybody's temperatures, but there should be a way to share education with those that are visiting the facility, and then also your healthcare workers of not coming in when they're positive, or they've if a visitor's had a close contact exposure. Granted, these are some ways to broadly make sure that people are aware of the information, but it doesn't have to be done on an individual level.
Great, thank you, Melanie. And we do have another question in the Q&A from Wade.
Okay, so the question is, dropping to medium then low would still be considered high like it is now. Do we have to stay at the same level for 2 weeks or just decrease in level?
So again, there's no hard guidance on what the facility will do based off of when the admission levels change. This is, again, making sure that you've got something written down of what will happen when the level moves from either high to low or low to high. So like you all were doing with the community transmission levels, if and again, if this was something that worked for you all, you can stick with waiting 2 weeks. If it moved from a high to a low, and then if it went up, you would implement prevention practices immediately, or you essentially will just change your practices as the levels move from one to the other. So it's really going to be dependent on what is going to be set forth for your facility, and it's going to be at the facility level what will be done when the metrics move from you know, high to low or low to medium.
Thanks, Melanie.
And Melanie, if I can just add, just from practical experience, you know, it's challenging to keep up with constant changes for the staff, and what level are we at today if it changed, you know, mid part of their shifts, you know. So that 2-week buffer to look for stability kind of helps keep everyone on the same page, and it decreases the up and down changes, so that those implementations are just easier across the board. So I like that period of stability before making a change, just because it's easier for the staff to digest.
Okay, thank you, Amy, and thank you, Melanie, and thanks to all of our stakeholders and panelists on the call today. And most of all, we want to thank the providers for joining us today. Your engagement is always spot on, and we hope that you have gained some clarification from today's presentation. Melanie, so nice to see your beautiful face and you back with us and offering all this guidance. Thank you so very much. We do anticipate some other office hour calls. So just be on the lookout for that information from the Alabama Nursing Home Association. And as always, this team is in communication, so you can send other questions or comments that come to mind, and we'll be sure to communicate that with one another. And the presentation will be sent out. Is that going to go out? How will that go out, the presentation today?
I'll send it to all of our moderators, and it can be sent to the list of participants on today's call.
Thank you. Before we close, I just want to touch base with Katrina to ensure you don't have any closing remarks.
No, ma'am, I don't, and I'd be happy to share any information with all of our members via our newsletter this week regarding this call.
Thank you, Katrina. And we apologize for going over 7 or 8 minutes, but it was well worth the information shared. Thank you again for your time, and we look forward to meeting with you again in the upcoming weeks. Everyone have a great afternoon.